Good morning. I convene this hearing of the Subcommittee on Oversight and Investigations to review the implementation of the Patient Protection and Affordable Care Act. Our first witness this morning, Mr. Andy Slavitt, the Principal Deputy Administrator at the Centers for Medicare and Medicaid Services. This is Mr. Slavitt's first testimony as a CMS employee, but not his first appearance before this subcommittee. Some of you may recall that Mr. Slavitt appeared before us last October to testify on behalf of one of the contractors who built the healthcare.gov site, so welcome back. Our ongoing concern about healthcare.gov is one of the reasons that we are holding this hearing today. Exactly 1 year ago this week, members of this committee will remember that we heard from CMS Administrator Tavener, who told us that healthcare.gov would be ready on October 1st. We were told that it would work, everything would be fine, and later we found out that that wasn't quite the same thing. In fact, the contractors told us the same thing, that it would not be, that it would be working. Our reviews of the website were brushed aside, but we know how our fears of a massive flop were well founded. The rollout of the Affordable Care Act was an unmitigated disaster. I think everybody agrees with that. So, Mr. Slavitt, we hope to hear from you today candidly and honestly about how things are progressing, and frankly, we hope we hear with the same candor from you as an administration official that we heard last fall when you testified on behalf of QSSI, the company that built the hub for healthcare.gov. Mr. Slavitt's new role also comes at an opportune time for the administration to address the systemic problems that led to the healthcare.gov disaster. After Mr. Slavitt's testimony, we'll hear from William Woods with the Government Accountability Office. Today, the GAO has released a review of the failed October 1 launch of healthcare.gov, confirming what this committee learned during its own review of the website. The administration didn't have the expertise, couldn't meet deadlines, and didn't have the leadership or organizational skills to manage this massive undertaking. And GAO also has given us a price tag for this boondoggle. A broken website that the President promised would be as easy to use as any e-commerce site cost the taxpayers nearly $1 billion. That took a lot of taxpayers' money and their hard-earned paychecks to come up with that $1 billion, and many taxpayers aren't happy about that. We'll also hear from the GAO that these costs are still going up. Some of my colleagues may whine and complain that we're spending too much time examining the failed website launch. I'm not surprised. They don't want to talk about it, but the reality is these problems are still playing out and may impact this fall's open enrollment period. We still do not know if the administration has a system in place capable of handling inconsistencies, inaccurate subsidies, web security, or whether CMS will ever put in place a functioning payment system. We will ask today about the healthcare.gov contracts and the GAO report, but as we head into open enrollment this fall, patients and families need to know how this law will affect them, because each day the ACA is making our healthcare system more expensive, fragmented, and restrictive. Early this summer, insurers were required to notify the administration plans for premium rates in 2015. We hope the witnesses today will provide information on the rates that have been submitted, when the public will know them with enough time to plan for their purchase, and whether the public will ever see $2,500 in savings that the President promised. Speaking of promises, we also want to know if Americans were able to keep their doctor and if they were able to keep their plan if they liked it. Earlier this year, this committee heard testimony from representatives of the insurance industry who noted that the requirements in the health care law require the cancellation of millions of policies. We hope to hear whether the administration predicts widespread cancellations and uncertainty again this fall. And it is not only individual plans that we are concerned about. Last week, the IRS finally began releasing information related to the enforcement of the employer mandate. This may be surprising to many. The administration has, after all, delayed this several times. But it certainly raises questions about what will happen when one of the law's most controversial pieces finally goes into effect. Finally, I remain concerned about the overall impact of this law. Millions of Americans have their health insurance canceled because of the law, only to find that the plans they are now forced to buy are much more expensive, and premiums, co-pays, deductibles are all the above. Some people may qualify for subsidies and others do not. At the same time, the law's massive cost and disruptive impact on the economy will continue to be felt for years. I again thank both the witnesses for testifying and now recognize the ranking member for 5 minutes.
Thank you so much, Mr. Chairman. Well, I've got to say, I don't really think we could go on August recess without having another hearing on the Affordable Care Act, because this is now the 12th one we've had in the last 10 years. As I've been saying the last couple of years, the ACA oversight is a really important topic. But I'd feel a whole lot better if we were actually doing oversight on what's happening now with the ACA instead of just rehashing old issues over and over again. You are right. We will stipulate the rollout of the ACA was an unmitigated disaster, but I guess I'd like to know how long we're going to keep beating this drum, because when you look at what's happened since the unmitigated disaster of the rollout, things are actually improving. And just about every prediction that was made about the law has turned out to be wrong once we got going. So I think we should spend our time trying to figure out how to make the law work even better for the millions of Americans who are now enrolling and getting health insurance. So in the last year, we had hearings where the majority insisted that Americans would be hit by insurance rate shock. Instead, the majority of new enrollees in ACA coverage are paying less than $100 a month. The majority insisted that the broken healthcare.gov website would never be fixed, but thank goodness it was, and millions of Americans used it to sign up for coverage. They insisted that many Americans would not pay for coverage once they signed up, but the insurers all came in here and told us that was not correct, that people in fact were paying. They insisted that 2015 premiums would skyrocket, but again, that's proving not to be true. In fact, in many cases, enrollees will be able to reduce their premiums next year. They insisted that Americans did not want or need health insurance coverage, but over 20 million Americans have received coverage under the ACA, and the uninsurance rate has dropped precipitously since January. The vast majority of new enrollees are happy with their plans. Now, these are important facts, Mr. Chairman, and in the interest of making the hearing as fact-based as possible, I want to talk about some fact sheets released earlier today by the Energy and Commerce Democratic staff on the benefits of the Affordable Care Act in every congressional district in the country. I'd ask unanimous consent to enter the fact sheets for each committee member into the record, Mr. Chairman.
Without objection, so
Thank you. And I just want to talk about some of the benefits of the law in my home state of Colorado. In Colorado, there are 240,000 state residents who were previously uninsured, but who now have quality, affordable health coverage because of the Affordable Care Act. In Colorado, our uninsured state residents has declined by about a third. Almost 2.1 million people in Colorado, including 460,000 children and 860,000 women, now have health insurance that covers preventative services without any co-payments or deductibles. 50,000 young adults in Colorado retain health coverage through their parents' plans. More than 40,000 seniors have received Medicare Part D drug discounts worth $118 million. 1.8 people in Colorado are protected by ACA provisions that prevent insurance companies from spending more than 20% of their premiums on profits and administrative overhead. Because of these protections, over 210,000 individuals in the state received approximately $41.7 million in insurance company rebates. Up to 294,000 children in Colorado with pre-existing health conditions can no longer be denied coverage by insurers. So even if you disagree with the law, it's important to note that the ACA is helping our constituents. I hope we can end these relentless attacks and we can help more constituents obtain coverage under the law. We should look at the example for Medicare Part D. I can attest to it because I was here. Many Democrats, including me, did not vote for the law and had real concerns about how it was implemented. But we still had town hall meetings and other events so that our seniors got coverage that cut their drug costs. I hope we can work as we look into the next year in a bipartisan way to make the ACA even better instead of trying to find ways to undermine and repeal it. Now, I appreciate the witnesses coming today. I know GAO has some important insights into CMS contracting for healthcare.gov, and anything we can do to improve that contracting is good for me. I hope CMS has learned from the website's flawed launch, and I want to know the plan to make sure they do better moving forward. And I want to welcome you, Mr. Slavitt. You're new to CMS. You'll have primary responsibility for the website. So I hope you can tell us what you plan to do in 2015. Thank you, Mr. Chairman.
The only time has expired. Now recognize Dr. Burgess for 5 minutes.
Thank the Chairman for the recognition. Thank you, Mr. Slavitt, for joining us here again at our subcommittee. You know, throughout the development and the rollout of healthcare.gov, this subcommittee had repeated assurances that the systems were and would be ready to go and that implementation was on track. At a hearing in September, literally days before the October 1st launch of healthcare.gov, we had repeated assurances from the then director of the Center for Consumer Information and Insurance Oversight, Mr. Gary Cohen. He said unambiguously that on October 1st, Americans would be able to go online, would be able to see premium net of subsidy, and would be able to sign up. We all know now that those assertions were fact-challenged. The Center for Medicare and Medicaid Services undertook this mammoth project without effectively planning for its development or its oversight. This has led to hundreds of millions of taxpayer dollars being wasted. Again, Gary Cohen and other HHS officials told us time and again that the website was working. That was factually incorrect. It was not working, and it still may not be working because the back-end systems, those systems that are responsible for actually paying providers, have not been built. Consumers may believe the website is fixed because some of the front-end problems have been addressed, but there's no way to verify inaccuracies about things like citizenship and income level or ensure that the correct subsidies are being paid for insurance premiums. Thanks to this investigation, we now have definitive proof that the Department of Health and Human Services was fully aware that these systems were not ready for prime time. Their own contracting documents show that they only expected 65% of the federal exchange to be ready on October 1st. And then, of course, we're continuously reminded that the promises made by the administration simply could not be kept because the groundwork had not been done and the website was not prepared. We are all still wondering what happened to the promised $2,500 in premium savings that every family in America could look forward to. We're all wondering what happened to the ability for people to keep their doctors. We're all wondering what happened to the ability for people to be able to keep their insurance plan. And Mr. Slavitt, Mr. Cohen also was asked at his last appearance here in January about the issue on the risk corridors and risk sharing. The question came up about what if there is not enough money in the risk corridor to actually cover the premium shortfalls that the insurance companies are experiencing. And would he look to, that was Mr. Cohen, would he look to supplementing those funds from general revenue of the Treasury of the United States? He couldn't answer the question. I asked him if he could provide us with a legal memorandum upon which he relied to obtain the ability to get funding from other sources if the internal funding was not enough to cover the cost of the risk corridors. That was January. I'm still waiting. I would like to know if I'm going to receive an answer to that question, and if so, when that answer might be forthcoming. Fact of the matter is, both the Department of Health and Human Services and the White House failed to heed internal and external warnings about the lack of readiness of the exchanges. Now we have the General Accountability Office report, and it is astonishing to see that after all the money has been spent, not all of it wisely, the agency continues to ignore recommendations and continues to pump money into what may be a futile effort. We're well on track to sink over $1 billion into the development of this website. We have very little to show for our money. I'm eager for the testimony of the witnesses today. I thank the Chairman for the recognition. I'll yield back the time.
The Chairman yields back. Now recognize The ranking member of the full committee, Mr. Waxman, for 5 minutes.
Thank you very much, Mr. Chairman. This is the 12th hearing this committee has held on the Affordable Care Act since enrollment began in October 2013. These hearings, if you look at them, all have one purpose: to undermine the Affordable Care Act regardless of the facts. The hearings have misled the public and, I think, squandered taxpayers' dollars. In fact, the Affordable Care Act is an historic success. It has made comprehensive health care reform a reality for the American people. More than 8 million people have signed up for private health insurance plans through the federal and state marketplaces, exceeding CBO's enrollment estimates by over 1 million people. An additional 6.7 million individuals have enrolled in Medicaid or the CHIP program as of May of this year. 3 million young adults under the age 26 have enrolled in their parents' health insurance plans. And the fact sheets that Democrats put out from our staff reveal that in my district alone, if I can be parochial, 17,000 residents who were previously uninsured now have quality, affordable health coverage because of the Affordable Care Act. So I'm giving some perspective. The law has been a success. It is accomplishing what Congress and President Obama intended. Instead, we have another hearing of this committee or another subcommittee of this full committee trying to say how the Affordable Care Act has problems and did things wrong and presumably should lead us to the conclusion it should be repealed. Well, in a lawsuit, there's a word called stipulate. We can stipulate to what the GAO has reported, and they have reported some things for which we ought to be concerned. Because despite the success of the law, the initial rollout of healthcare.gov had serious flaws. And I'm glad we're going to hear from GAO, the Government Accountability Office, on their investigation of healthcare.gov contracting. We should always try to learn from mistakes, not dwell on them, but learn from them. And I'm glad that Mr. Slavitt is here to tell us what the administration has learned and what is being changed as a result. I've had experience with flawed contracts. I was the chairman of the Oversight Committee, and we released a report that identified nearly 200 contracts worth over $1 trillion that involved significant waste, fraud, abuse, or mismanagement. The FBI had a contract to create a virtual case file system that had to be canceled after spending over $100 million. The Department of Homeland Security's contract to build a high-tech border fence. That was supposed to keep out all these immigrants. We're still having problems. That fence had to be canceled after wasting $1 billion. The Coast Guard had a multi-billion-dollar deep water contract built boats that would not float. Now, my point is not to excuse the healthcare.gov problems, but to put them in context. With the exception of Tom Davis, congressional Republicans showed little interest in these enormous wastes of taxpayers' dollars when George W. Bush was president. I think we should care about waste, fraud, and abuse no matter who is president. And I'm proud that healthcare.gov was fixed quickly. Not as quickly as I would have liked, but fixed nevertheless, and in time to help millions of Americans enroll for insurance coverage. But I want to learn what went wrong so CMS can do a better job for the next time. Not the way the Republicans handle this. See, we told you so. There are problems. We told you there would be problems. Okay. And then their conclusion is repeal it so they can replace it. But they've never given us a replacement. Well, people are getting insurance who couldn't get it in the past because they had pre-existing medical conditions. People are finding that their insurance can't be canceled on them after they paid just because they got sick. Women are not discriminated against. People who couldn't afford it can now get insurance because we give them tax breaks in order to pay for it. So I'm eager to learn what the agency is doing so enrollment in 2015 goes more smoothly. We have unequivocal proof that healthcare reform is a success. We now need to make the 2015 enrollment period as smooth as possible so we can build on this success. Let's go toward trying to make things better, not dwell on things that were wrong, especially if you learn the lessons and fix the problems.
Gentlemen, time has expired. Just a message to members and to our folks giving testimony today. We're expecting votes around 10:30, 11, 10:25, 10:40, I should say. And so we're going to try and go through this. I will have a quick gavel, and I ask that all members really stick with their 5 minutes as we go through this, or I'll really bang it hard. And then we will move forward. If we need to be interrupted by votes, we'll come back right after votes to complete things. So I'd now like to introduce the witness on the first panel for today's hearing. Mr. Andy Slavitt is the Principal Deputy Administrator for the Centers for Medicare and Medicaid Services. In his new role, he will be responsible for agency-wide policy and operational program coordination as part of a new management structure that comes in response to lessons learned from the rollout of healthcare.gov and recommendations put forth to the Secretary. I'll now swear in the witness. You're aware that the committee is holding an investigative hearing, and when doing so has the practice of taking testimony under oath. Do you have any objections to testify under oath?
No, I don't.
And the chair advised you that under the rules of the House and rules of the committee, you are entitled to be advised by counsel. You desire to be advised by counsel during today's testimony. In that case, would you please rise, raise your right hand, I'll swear you in. Do you swear the testimony you're about to give is the truth, the whole truth, and nothing but the truth?
I do.
Thank you. The witnesses answer the affirmative, so you are now under oath and subject to the penalties set forth in Title 18, Section 1001 of the United States Code. You may now give a 5-minute summary of your written statement. Mr. Slavitt.
Good morning, Chairman Murphy, Ranking Member DeGette, and members of the subcommittee. I'm Andy Slavitt, Principal Deputy Administrator of CMS. I joined CMS 3 weeks ago from the private sector, where I spent the last 20 years principally working with physicians, hospitals, health plans, and employers on solutions to problems of healthcare cost, quality, and access. In the private sector, I both started my own healthcare technology business and run larger-scale health services organizations with more than 30,000 employees. In late October of last year, I began my involvement with the Affordable Care Act implementation when I joined a group of people helping the CMS team on the turnaround effort of the health insurance marketplace. I'm very pleased to appear before you today, and before answering your questions, we'll briefly walk you through some of the progress of the Affordable Care Act to date and talk about our priorities for the coming period. There is growing evidence that suggests that the Affordable Care Act is making a difference in the lives of millions of Americans. In the first full year, millions of Americans selected a private insurance plan through the state or federal health exchange marketplace, and millions more have retained coverage on their parents' policies or have qualified for Medicaid or CHIP. In addition, we're seeing historically low growth in overall health spending, which has continued into 2014. This is good news for consumers, with the typical premium paid for a policy purchased in the marketplace under $100, and good news for taxpayers, as the recent Medicare Trust Fund report shows. And importantly, this success is not being achieved by government policy alone, but in partnership with the private sector, as insurers grow by competing to provide better access to quality, affordable services. Now, as we move into our second year of marketplace implementation, we must build on the progress that's underway and heed the lessons of the last year. Let me outline for you our highest priorities. First, we are focused on increasing the value consumers get when they come to the marketplace. This means continuing to improve the information, plan options, and affordability of the shopping experience. Second, we have critical technical and operational priorities. We must continually add automation. That has begun with critical releases this summer and will continue this year and in following years. While the consumer-facing website is, of course, live, we are adding functionality to allow consumers to easily renew their coverage. Whether on the consumer-facing side or the back end, our technology improvements will be more continuous and more incremental. We have a very strong sense of our critical path. Our software releases so far have been on time, and we are managing these deliverables daily. Third, let me address our management priorities to improve execution. As part of the turnaround team, I experienced firsthand the challenges of the first year of marketplace implementation. And at CMS, I'm now helping to oversee a series of changes to improve the management of the marketplace. As Secretary Burwell announced in June, we've created clear top-down accountability. We have also improved the management and communication with our key contractor with better defined requirements, metrics-driven contract reviews, and requirements for skin in the game. We've expanded our testing protocols and built more testing into the schedule. Even as we address the major concerns from last year, new ones will emerge, and our management structure and team must surface and address issues in a disciplined manner, just as we did during the turnaround. This coming year will be one of visible and continued improvement, but not perfection. We are in the early stages of a program newly serving millions of consumers and are still learning about the best ways to support their unique needs. And we are setting up and testing new processes and new technologies along the way. From my experience, at this stage, businesses begin to see how closely their design matches the battle-tested needs of the market. Good organizations focus, prioritize, and learn and continuously improve their operations and the services they provide. It is not always easy, but we understand what we need to do and are making the right progress to have a successful open enrollment and continue to deliver on the promise of the Affordable Care Act to improve health care access, cost, and quality for all Americans. Thanks, and I look forward to your questions.
Thank you. I appreciate your comments and appreciate your candor here before, because my very first job when I was a young man was mucking out horse stalls. And I felt like the difference between what I got to do is I got to ride the horses. It was a nice reward. The difference between that job and this job is I don't get to ride the horses anymore. So I appreciate your honesty and candor in this, and want to ask you some questions along those lines. You may recall that a year ago, Congress was told repeatedly the healthcare.gov website was fine, it was ready. To the months, days, and weeks leading up to it, everything was ready to go. And the President said it would mirror the public's experience with other websites. So we have to ask, will healthcare.gov be fully ready this fall?
So, thank you, Chairman. So I obviously wasn't here last year. It does sound like, certainly from the GAO report that I've seen, that a couple of things happened. First, the technology build was certainly bigger and more complicated than people expected, and I think the scope expanded because of that. And secondly, as the GAO pointed out, there were some significant issues with the management of the project.
But for the future, is it good? Because you said it wasn't be perfection, so are there going to be hiccups this fall too?
I'm sorry?
Are there going to be some hiccups in the website implementation this fall?
I think this year we can expect we're in a vastly different situation. For one, we have a website that's already up and live and running.
Yeah.
We're adding continued improvements, and we're adding them in a much less risky fashion. We're doing releases frequently over the course of the summer, putting things live into production. We've built in a big testing window. So everybody will remain on their toes and nervous. Everybody knows what they need to do, but we're expecting to have a good open enrollment.
But the GAO said there were still significant risks for the next open enrollment period. So you're saying everything's going to be fine and ready?
I think our job is to manage those risks, understand those risks, surface them.
I don't want to take out my shovel. I just want to know. Because if there's going to be problems, I would much rather you just tell the committee, look, we anticipate these problems. Here's the actions we're taking to move forward. I think the whole committee would appreciate that, so we don't have to get caught up in this guess game.
Sure. Well, I expect that it won't be perfect with serving millions of people. There are certainly difficult situations. Many of whom are enrolling in insurance for the first time. It's a bumpy process at times. I think we've got a committed team of people, though, that by and large are doing a very good job, but there will clearly be bumps. Any
anticipation how many more people you'll be enrolling in the fall? Or how many will be enrolling for the first time?
I don't know that.
Do you know, in terms of your review of this, so far of those who have enrolled, how many of those have enrolled for the first time?
I've only seen the media reports, which I can't pull a number, but it was I think far greater than half. But I've only seen that in the media.
When Secretary Sebelius was here before, I asked her a series of questions. I'll repeat those to you. But I asked her how many were new, how many were people who had previously had insurance and got a pink slip and was discontinued, how many were people who were newly eligible because of Medicaid, and of all those who signed up, how many were paying the same, less, or more. Mm-hmm. And she said really the website has there's no way of knowing any of those things. Would you agree that's true?
Yeah, I think that data is not yet known by us. I think we're getting a bead on what premiums people are paying. Mm-hmm. So that's good. We have a sense that there is good affordability offer to.
But when we see these numbers of how many people signed up, 10 million, 11 million, whatever it is, compared to the 45 million for which there was a need for health insurance, we really still don't know how many of that original 45 million are served new by this.
So the administrator has a chart in her office which she calls her prettiest picture, and it's a graph of the uninsured rate over time, and it shows a drop to 13%.
So is that specifically reviewed by your office or by HHS to specifically look at people who were uninsured before and now are insured? Because you just told me that you can't really determine that, and Secretary Sebelius told me there was no way of knowing that.
Yeah, there's no way to determine that from the website. We do know the uninsured rate from the recent Gallup report is down to 13%.
Have you tried to sign up for one of the plans on the website?
I have, now that I'm a federal employee, I'm in the FEHVP Blue Cross plan.
So you don't have to be in the Affordable Care Act yourself?
I'm a federal employee.
Yeah, well, okay. And I'm just curious, have you also reviewed with people if they've tried to access their physicians? The plan allows that initial visit and some other preventive care, not as much as preventive care as I like, but have you surveyed persons to find out if they've been able to see their physicians for follow-up appointments, their costs, for example, reviewed their costs, their payment levels, their copay, their deductibles, have reviewed any of those things? And
I'll have to get back to you on that. I don't think we have any hard data, but I can certainly look and try to follow up.
Thank you. I'll keep track of time here, and Mr. Gett, you're recognized for 5 minutes.
Thank you, Mr. Chairman. And so I agree that it's important to make the Federal Exchange website and also the states work as well for people. And I'm sure, Mr. Slavitt, you agree with that too, don't you?
Yes, I do.
And we want to make it as easy as we can for people to enroll, and especially as we re-enroll in the 2015 plans. Is that correct?
That's correct, Congressman.
Now, up till now, even despite the admitted problems with the website, 8 million people enrolled in the marketplaces. Is that correct?
Correct.
And about 6.7 million enrolled in the Medicaid expansion. Is that right?
That's right.
So obviously, people were able to utilize those websites to get health insurance. Is that right?
That's correct.
Now, I was looking at the part of the GAO report, and the GAO made 5 recommendations in the report. Are you aware of that?
Yes, I am.
And what is your opinion of those recommendations?
We agree with most of those recommendations.
Which ones don't you agree with?
I think the only thing in the GAO report that I think needs a little further clarification, it's not that I don't necessarily agree with it, it's the characterization of the Accenture contract. And I think it was characterized as ballooning in cost when, in fact, I think the Accenture contract was, there was an initial contract before the work was completely scoped.
Okay, but let me stop you, because that was one of their findings, but that wasn't one of their recommendations. Their recommendations...
Correct. So I agree with all of their recommendations.
You agree with all 5 of their recommendations. And what steps are you taking to implement those recommendations?
So we are doing a number of things. First of all, in the contracting front, it is very clear now who can give work to Accenture, how work gets approved, how that contract gets managed, and frankly, importantly, Accenture has skin in the game to make sure that they deliver. Again, I wasn't here last year, so I can't speak precisely to how the project was managed, but I can tell you that now there is daily intensive management of the project. Risks and issues and concerns are all surfaced and dealt with. We've built early warning indicators. So there's and then there's an accountability difference that I think is very significant.
Are you looking at the interoperability issues as well? That was one of the problems we had before.
This is, as you point out, Congresswoman, many different pieces of this project in order to go well, and so the coordination and the systems integration is something that I think was missing last year, and it's in place this year.
Now, are you doing anything that goes beyond the recommendations in this GAO report, Mr. Slavitt?
Yes. Well, fortunately or unfortunately, the GAO report wasn't news to the people at CMS. I think the people at CMS who worked awfully hard but lived through that nightmare don't want to go through that again. So I think actions were underway well before seeing this report, and I think they fall into the categories that I've talked about: contracting reform, technical and managerial oversight, focus and discipline project management.
Now, we keep hearing about how expensive the cost overruns and everything else in setting up healthcare.gov were. Just as an aside, Mr. Chairman, I'd like to know how much this lawsuit against the president is going to cost. But be that as it may, Mr. Slavitt, I want to ask you, do you think we're going to be protected from cost overruns for the 2015 enrollment period?
So, again, I wasn't here last year, but the two things that went wrong last year, one of them actually was simply the inability for anybody, and quite reasonably so, and this happens in the private sector, to estimate how big this project is and how complex it is. We've got a better handle on that now. I don't expect those overruns. Secondly, to the point of the GAO report, the contractor wasn't managed tightly with clear deliverables and requirements. That's been put to bed as well. So those two things are in much, much better shape.
And were you aware, one last question, were you aware that the uninsured rate in this country dropped 25% after the implementation of healthcare.gov and the full implementation of the ACA?
Yes, Congressman, that sounds right.
Thank you. I'll yield back, Mr. Chairman.
Now recognize Mr. Harper for 5 minutes.
Thank you, Mr. Chairman, and thank you for being here today. And have a couple of questions I'd like to ask. First of all, who is performing the role of systems integrator now? Who's doing that?
Optum. The firm is Optum.
Okay, I'm sorry.
My prior company.
And so who has that role now?
Optum, the firm. Optum does.
Okay.
Plays that role.
I got you. Yeah. Some questions I'd like to ask about some reports. Earlier this summer, we learned that there were nearly 4 million inconsistencies in the applications submitted via healthcare.gov. Those inconsistencies are primarily for citizenship status or income. The failure to calculate these properly could mean that millions of Americans could have to pay back incorrectly calculated subsidies. So earlier this summer, it was reported that there were millions of these. First of all, how did this happen? And can't the website check for accuracy?
Sure. So appreciate the question. Inconsistencies occur because of the changes that occur in people's lives. And people end up having more current information than government databases. So we've run, last year during open enrollment, hundreds of millions of checks against government databases to check on income and citizenship status and so forth. And some occasions where people particularly are in low-wage jobs, they're in seasonal work, and other kinds of circumstance, their income is unpredictable. Or in other cases, they haven't filed taxes before because they haven't made enough money. So what happens when that happens, and just to give you a perspective on this, for a typical family of 4, there are 21 records searched through our automated process. If even one of those records turns up not to be a match because of income or some other thing, we have to pursue documentation, and we do indeed pursue documentation to try to ensure that these people are in fact telling the truth. And as we've done that, I'm sorry.
How could a person on a form be a citizen or not be a citizen? Is that something that you can verify?
There's documentation status. There's whether it's a naturalization status and so forth. Those are sometimes not as current in the government database as what the individual resident has in fact done in their life.
So in an application, on one application could have multiple inconsistencies, correct?
That's correct.
And do you have a number of how many Americans were affected by this problem?
So I think there were a couple of million people who had inconsistent information that needed to be matched of some form or another. About, I'd say roughly half of those are income changes. So these are people who will have to come back to the website, and we're urging people to do that, make some adjustment because it will spill out, of course, on their tax form. Of the other half, we've cleared, as of July 1st, 425,000 inconsistencies, and greater than 90% of those are indeed in favor of the individual consumer who had more up-to-date information than we did.
You know, and this is obviously something we want to make sure doesn't continue. So what assurances can you give us today that we won't see these problems during the next enrollment period?
Well, I think what we're learning is that a certain amount of these data discrepancy problems are going to be a fact of life because of the fact that we have people who do have high variations in their income levels, and so that's going to occur in coming years. What's going to be different next year is we've now just released software that allows us to get at those inconsistencies much more quickly. What's important, though, is that people who we reach out to, who we need additional documentation from, get in touch with us and get them back to us.
Thank you, sir, and I'll yield back.
Mr. Tonko for 5 minutes.
Thank you, Mr. Chair. Mr. Slavitt, welcome. And you earlier went through some national stats, and I've received information on my district. We've been waiting to get info, and in the 20th Congressional District in New York, 11,000 residents who were previously uninsured now have quality, affordable health coverage because of ACA. The number of uninsured residents in my district has declined by some 23%. 214,000 individuals in the district, including 137,000 women and 54,000 children, now have health insurance that covers preventative services without any co-pays, co-insurance, or deductible. And 262,000 individuals in my district now have insurance that cannot place annual or lifetime limits on their coverage. And up to 37,000 children in my district with pre-existing conditions can no longer be denied coverage for health insurance purposes. I think that's a tremendous bit of improvement. We obviously want to continue to grow those numbers, but it's comforting to know that that kind of success is coming the way of our district. And so, Mr. Slavitt, part of the promise of creating the one-stop marketplaces was the ability to shop for health plans side by side and in an apples-to-apples comparison. While the federal healthcare.gov site has done a good job in this regard in displaying the premiums and deductibles of various plans, it has been more difficult to assess differences in health plan networks or whether a particular doctor is in network for a given plan. Could you tell us what CMS is doing to make it easier for consumers to access this information in advance of the upcoming open enrollment period?
Thank you, Congressman. So you're indeed correct. And in fact, in last year, I believe the typical consumer had several dozens of options to choose from in health insurance, and our job is to try to continue to grow that. But as you point out, we have to make the information people are looking for more readily apparent, more easy to see. So we are asking the insurance companies this year to put direct links to the provider directory that fits the individual plan. But I would also just ask consumers to do, and I would ask if you talk to people in your district, is that those directories that the insurance companies keep, they're not always up to date. They try to keep them up to date, but it's always good to call the insurance company or to check with if there's a physician that you want to see to make sure that they're in the network, because this is really important information for people to choose from. Okay.
And in terms of allowing a consumer, for example, to search only for plans in which their doctor is covered,
we don't have that ability. That's the kind of thing that might come in future years.
What kind of obstacles stand in the way of that happening?
You know, I think one of the lessons learned from of this project is to take disciplined, incremental steps to making progress, not trying to do too much. And you know, our schedule is pretty much filled with things that are important to make sure we're executing well. And I think those are the kinds of innovations that I could really see us getting excited about adding in future years, but it didn't make the cut this year.
Mm-hmm. And if I could just ask you a quick question about the Medicare Trust Fund. The trustees report, as you know, came out on Monday, and they're talking about the fund being secure through 2030. That's 13 years longer than was projected in 2009 when the ACA was passed. The report noted that these changes may be due to the cost-saving provisions of the ACA. Do you believe that to be correct?
Well, I'm not going to hold myself out as an expert, but it sounds logical.
And in fact, since passage of the ACA, the Medicare costs have grown at or near record lows. Is that not correct?
That is correct.
So would you anticipate any continuing or additional benefits coming via Medicare?
Yes, I would.
Okay. Well, we appreciate the leadership that you have borne with the ACA, and we thank you for the improvements. And I know on behalf of the district that I represent, the numbers are very encouraging. I shared them with you here this morning, and we're going to continue to work to further improve so that one of these fundamental rights, the affordable and accessible quality health care for all, is continued and strengthened. So with that, I yield back, and thank you, Mr. Chair.
Gentleman's time has expired. Now recognize Mr. Griffith for 5 minutes.
Thank you, Mr. Chairman. I do appreciate that, Mr. Slavitt. Thank you for being here this morning. You've indicated and testified that you were previously employed by Optum QSSI. Is that correct?
That's correct.
And I think I heard you say in your opening statement that you left their employee approximately 3 weeks ago. Is that also correct?
A little longer than that. Yes, that's correct.
A little longer. How long?
I'll get you the exact date.
Well, I don't need the exact date. Between 3 and 4 weeks?
Something in that nature.
Yeah. Here's the question. You now work for CMS, and from what I understand, you're a very talented individual, and that's a good thing for CMS. But if I understood your testimony as well, you've indicated that your previous employer is managing the website as the systems integrator. Is that correct?
That's correct.
Okay. So then the natural question as an oversight committee is, how are you able to manage your former employer, and doesn't this create a conflict of interest?
Sure. Yeah, thank you for the question. So, Congressman, there is, as you know, an ethics pledge that I signed, and along with that, disposed of all of my stock, basically, that I'd had in the company, and completely used myself.
You disposed of all of your stock? You said basically.
Yeah, all of, yes.
Okay.
Yes, I'm not trying to qualify that.
I didn't think you were, but
okay.
I wanted to make sure on the record that you got rid of all of your stock.
Yes, got rid of all my stock and any other ties as appropriate. I have signed, and not qualifying with as appropriate, as was appropriate. So now as a public servant, I have a very clear set of rules to follow. I have this ethics pledge, and then within that ethics pledge, I have a limited waiver, which allows me, for the purposes of health reform implementation only on the website, to be able to interact with all of the contractors, including Optum, solely as it befits the implementation of the project. And so I do that and exercise that very carefully and very prudently. But that's a publicly available waiver that I can make sure to get to you if you'd like.
If you would, that would be great.
Okay.
And then I would like to talk about that waiver process, because normally, in my experience, when you move from the private sector into the public sector, there's usually some kind of a period of not dealing with your former employer that's usually a year or more. And if you could explain that process, how they came to this, and you said it was a limited waiver.
Sure.
We'll look at that later. But if you could explain that process, I'd appreciate it.
Yeah. So it's I think a 15-page document, and I can get you the details.
I would appreciate that.
But it's a 2 years is the waiver, and I think the only exception. 2 years is the agreement not to communicate with my old employer, and then there's this narrow exception for interaction relative to this implementation process.
All right. And I appreciate that. Let me ask you some questions about your former employer, because Optum QSSI is a subdivision or is a subsidiary of United Health Group. Isn't that correct?
That's correct.
And in their 417 quarter one of this year earnings call, the United Health Group president and CEO Stephen J. Helmsley recognized employees and said that, we try to move our employees around in different divisions of the company. And so I'm a little concerned about how much of a firewall is built between Optum QSSI and United Health Group, because United Health Group is participating in some of the exchanges and in the federal exchange. And so we have a situation where, again, there's an appearance of a conflict or impropriety, because if you're shifting folks around, I said to one of my staffers this morning, well, they have a machine like they did on Men in Black, and they zap their memories and they remember nothing that they saw, because it would appear that the folks at QSSI who then report to United Health Group, and in fact, Larry Renfro has an office, a title or a hat in both companies, and if that's the case, aren't they able then to gain information on competitors by participating in the process and in all these meetings, and then get an advantage over their competitors in the healthcare websites?
So let me clarify two things.
Okay, please.
First, nobody on the healthcare.gov project is permitted to go back and to go outside of the project and transfer into United Healthcare. That's expressly prohibited. Secondly, just important clarification, because it is a little bit confusing. United Healthcare and United Health Group are two different things. So United Health Group is a parent company.
Right.
It has two divisions. One is called Optum, one is United Healthcare. And so I don't want anybody to have the impression that Optum is a part of this insurance company. It's actually a sister company, a separately run entity.
Well, but it's a wholly owned subsidiary, is it?
Correct. Correct.
Gentleman's time's
All right.
expired.
Thank you. I'll have some follow-up questions that we'll present for answers after the meeting.
Okay. Thank you.
Thank you. Now recognize Ms. Castor for 5 minutes.
Thank you, Mr. Chairman. Good morning. Throughout the country, everyone's seeing the benefits of the Affordable Care Act. And as of today, Americans who are interested can access new fact sheets that provide statistics based upon each congressional district. So I encourage you to go to the Democratic website of the Energy and Commerce Committee or call your member, and we can provide those. I want to share some facts about the benefits of the law in my Florida district in the Tampa Bay area. There are over 24,000 individuals in my district who were previously uninsured, but now have quality affordable health coverage because of the Affordable Care Act. The number of uninsured in my district has declined by 15%. Now, that could have been higher if the Republican-controlled legislature and our governor would have expanded Medicaid in Florida. In fact, almost 1 million additional residents, Floridians, could have health insurance. That's 43,000 of my neighbors in the Tampa Bay area who could have been covered, but they remain uninsured because Florida refused to expand Medicaid. But over 40,000 people in my district were able to purchase coverage through the new health insurance marketplace, and nearly 10,000 young adults were able to retain coverage through their parents' plans. 43,000 of my older neighbors received Medicare Part D prescription drug discounts worth $8.2 million. I mean, that's a great shot in the arm and terrific money back into their pockets. So as we plan for the second year of open enrollment, we all want to make sure that we don't have the computer problems that we had last go-round. So I want to ask you some questions about premiums, especially for the 2015 period. Now, open enrollment begins in November. Is that correct?
Correct.
November
15th.
15th.
Yes.
So folks need to, at some point, when will the website be ready to compare plans?
So we're going to be sending out notices to people starting in October to come back to the website, update their information, and letting them know that on November 15th they'll be able to either, if they choose, come back to the website, shop for a plan, compare premiums, and choose the plan they want, or, as happens with Medicare Part D, Medicare Advantage, and most employers, if they choose to do nothing, they'll be able to automatically re-enroll if their existing plan is offered.
Okay, and the deadline is in February?
February 15.
February 15th of 2015.
2015.
Now, Republicans have predicted that premiums would skyrocket for the next go-round, increasing by as much as 50%. But we can now test those numbers because the new rates are rolling out across the country. Are there any signs of the out-of-control rate increases that the Republicans have predicted?
So far, the rate increases that have been publicly available from Rhode Island, Washington, Delaware have all been in the mid-single digits. California, I believe, has a big, is going to come out with their numbers today. So I think that'll be closely watched because of the size of the state. Colorado's, I believe, have been very steady by and large. So while this isn't going to be true for every single individual in every single county in America, by and large, the early results look positive, very positive.
Great. And is it accurate to say that there are more choices in the marketplace this go around, or will it depend upon the state?
But there will be more choices this year than last year.
So what does competition tend to do when consumers have more choices?
Better prices, better value, better services.
Does that mean that if you have greater competition, that puts pressure on the insurance companies to keep their premiums low?
I think this is one of those win-win situations where the private sector can grow by actually providing more value to consumers, and that appears to be what's happening.
And what else helps keep premiums low under the Affordable Care Act?
Well, certainly the preventive visits do, the ability for people to qualify for tax credits. I think there's a whole host of things that...
one of my favorite ones, what we did in the Affordable Care Act is the 80-20 rule, the medical loss ratio, that says when a consumer purchases a policy, they have to get something meaningful, and insurance companies can't spend too much on profits and administrative costs, and when they do, they have to rebate the money back to consumers. And because I represent the state of Florida, we're really happy that our consumers are going to receive $42 million back this summer. I've already heard from many of my neighbors, and sometimes those rebates go back to the employer, so you do need to keep an eye. Isn't that right?
Yeah, in fact, the numbers that I've seen are that something like $9 billion has been returned and saved to consumers in that process. That's
been very important in this day and age. Thank you very much.
Gentleman's time has expired. Now recognize Mr. Johnson for 5 minutes.
Thank you, Mr. Chairman. Mr. Slavitt, it's good to see you today. You and I have had chances to interact before, and I appreciate you being with us. I agree with Mr. Griffith based on your background. It looks like CMS is going to be the beneficiary of your experience and background.
Thank you.
You've talked about your many years in the private sector. Could you give a very quick summary of your years of experience and expertise and what it primarily focused on?
Sure. So I started my own health information technology company back in the 90s. It was a small business that ended up serving consumers, ended up selling that business. I worked within Optum for a number of years. I oversaw the health information technology business and grew that. Worked very closely on building lots of industry-wide capabilities around things like revenue cycle management, population health management. Worked closely with hospitals, with physician groups, with health insurance plans, state governments, all really focused on quality, cost, and access issues.
Okay. And to summarize, I think when you were responding to Mr. Griffith's questions, you led the team that basically made healthcare.gov usable in October, correct?
Correct.
Okay. So I want to ask you, you have all of those years of experience and expertise in information technology, specifically in the healthcare arena. How much should healthcare.gov have cost?
That's a really good question, and I'm not sure I know the answer to it. It is not unusual for large-scale health projects. For example, I can think of a big project from Kaiser Permanente when they installed electronic medical records. Cost a couple $2 billion to put in place. It's hard to know what the benchmark is to build a consumer-facing website and set of back-end systems that connect to 50 states, to Medicaid plans, to insurance companies. So I'm not quite sure.
Well, let me help you a little bit, because I don't know if you remember or not, but my background is a 30-year information technology professional, so I have been through the lessons learned and the trial by error of trying to project cost of complex IT systems like this. The GAO says that we spent nearly $1 billion on this, with the cost climbing. Do you believe that taxpayers have received a good return on their investment thus far?
Congressman, I think two things happened, and it's hard to know how much fits into each category. One thing that happened is clearly this was a more complex project and needed a lot more work than people expected, and for that part, I think...
And that goes back, yeah, and see, that goes back to the genesis of some of the questions that we got into the last time you and I were here. If you have a firm set of requirements, and if you have a systematic life cycle design process, it's much easier to project those costs. I know when I was doing large-scale program management on large IT systems, the industry general rule was that in the life cycle of a complex system, that the implementation part, the design, the building, the implementation part, is only about 25% of the cost, the life cycle cost of a system. The rest of the cost is in maintenance, operations, and further on down the road. So if this thing has already cost the taxpayers $1 billion or more to get to where we are today, we can reasonably expect that this is going to cost billions more over the life cycle of this thing, correct?
Yeah, I couldn't put an estimate on that.
But you do agree with the concept in general that maintenance and operation cost a heck of a lot more over time than the initial implementation does, right?
I do think there will be an ongoing operating cost. I don't know that it will be greater. I think I have to look, and I'd have to look at the budget request, which I don't have with me.
Okay, well, the budget request has nothing to do with how much it's going to cost. You understand how the industry works. You understand life cycle software development. You understand that, but I appreciate it that you don't really want to answer.
I don't know the answer.
GAO says ultimately more money was spent to get less capability. Do you agree with that?
I think there were clear inefficiencies.
Because a lot of it's still not working.
I think there were clear inefficiencies in how this was managed. I think what I'd also say, Congressman, is in the real world, it's not always possible to know your scope going in. It's always in an ideal world you can, but I think the estimates proved that they needed to do more work.
Thank you, Mr. Chairman. And I agree that it's not always possible to know the scope, but it is possible to fence the scope, and therefore knowing that what you're going to pay for is what you're going to get, which is clearly not what happened here. Thank you, Mr.
Gentleman's time is expired. I again remind members, please keep within the time frame because we're expecting votes in a few minutes. I want to be fair to everybody. Mr. Yarmouth, you're recognized for 5 minutes.
Thank you very much, Mr. Chairman. Mr. Slavitt, thank you for your testimony and your work. I want to talk about some of the things that have happened in Kentucky since we're actually doing an update, and I'm very proud of the experience we've had so far in my state. But there was actually some pretty astounding news earlier this week that regarding the trustees of Medicare, coming from them about the prospects for viability of the Medicare Trust Fund. Are you familiar with that information?
Yes, I am, Congressman.
Could you tell us what has happened? Because as I recall, when we passed the Affordable Care Act in 2010, at that time the trustees were projecting the trust fund would be insolvent by 2017.
I believe, if I'm not mistaken, that in summary, that the projection is the trust fund was life expectancy extended to 2030. 2030.
So that's pretty astounding that in 4 years the projection extended the viability of Medicare by 13 years. And there was also some fascinating, I think, impressive data about per beneficiary expenditures, that they essentially were flat year to year. There's no increase when historically they've been running at somewhere between 5 and 10% annually. Is that correct?
That's correct.
Right. Thank you. So one of the things that I know we've spent a lot of time talking about people who signed up for insurance in the private insurance in under the Affordable Care Act, but this is a data that's come about from the Commissioner of Medicaid in Kentucky, and I think this is so impressive. If you look at the top map, that is the 120 counties of Kentucky, color-coded by the amount of the percentage of uninsured citizens in those counties prior to the ACA. And red and orange, which are most of the counties in Kentucky, I think all but probably a dozen, were rates of 17 to 20% and then more than 20%. This is the bottom map is the current situation, and it's staggering to me that because the green is under 11%, 8 to 11%, and blues 5 to 8%, and the dark blue less than 5%. We have counties in Appalachia and southeastern Kentucky that went from having the highest uninsured rate in the state, over 20%, to the lowest uninsured rate, under 5%. And that, to me, is a staggering accomplishment. In Kentucky, we essentially have insured about half of the previously uninsured population of the Commonwealth in a state that has very poor health historically and currently, and people who are desperately in need of health care. And what's even more important, I think, than that is that the report of the Commissioner, of Medicaid in Kentucky, talked about how preventive service utilization has increased dramatically, almost 16% an annual dental visit, which they weren't doing before. Adult preventive services increased by almost 37%, breast cancer screening by 20%, colorectal cancer screening up by 16%. Very, very important health measures that I think will pay off for the Commonwealth economically, but also for the life of these citizens going forward. And also what's, I think, very important to note is how much reimbursements went up for providers in the Commonwealth. Totals of, reimbursements from those now covered under Medicaid expansion went up by $284 million in just the first 6 months. So many of those hospitals and doctors and other providers who were providing uncompensated care for Kentucky residents are now being compensated, and that also is a great benefit to the taxpayers and the Treasury of the Commonwealth. So I just mentioned those things because it's very clear to me that states that embrace the Affordable Care Act and committed to making it work are having very, very positive experiences. The adverse experiences are coming in states where the administrations of those states, the governments, decided in some cases just not to participate, and in other cases to try and sabotage the law. So I thank you for your work and for the information you brought to us today. I yield back.
Thank you. Gentleman yields back. Dr. Ginger is recognized for 5 minutes.
Ms. Slavitt, one of the members earlier asked or made the comment that because of the medical loss ratio, I think maybe they were talking about the state of Florida, how much money was returned to the consumer of health insurance through the plans. Let me start out by specifically asking you this, because this has also been reported. If an individual ended up receiving an incorrect subsidy that they were not entitled to, what will be done to rectify this issue? Specifically, will they be sent additional funding if the subsidy was too low? Or will they need to pay back the money if the subsidy was too high? And when will consumers know if they owe the government more money?
Yeah. Thank you for the question, Congressman. So if individuals have changes in their income, the best advice is they should come back to the website and update that information so that their tax credit and premium can be updated. For those adjustments that are not made when it comes to tax time, they will either receive a refund or they'll have additional that they'll owe.
Well, I think we need to get some specific answers on questions like that, because this pay and chase model, as we know in past, absolutely, in regard to, let's say, paying Medicare claims that were fraudulent, and then you have to go chase them down to try to get them back. You never do. You are aware of this GAO report that came out, well, I guess today, and it states that in January, CMS awarded a new company a contract to continue work on the federal marketplace for $91 million, right?
Correct.
GAO says in the report that the cost now has ballooned to more than $175 million. Is that correct?
That's what the report says, yes.
Yeah, right. And the investigation, of course, ended a few months ago. Do you know if the cost, this estimated cost of $91 million, that's now $175 million, that's in the report, has it gone up even further since the report?
No, I think the estimate of the total contract, and again, this is not what's been paid, this is what is being budgeted, is about $170 million. That's correct.
You know, that's a pretty big error, 91 million versus 175 million. How is it you can offer a contract for $91 million and have it grow that much over such a short period of time?
So I think the proper characterization of that contract is that the scope of the contract was completed after the initial contract was awarded. So I wouldn't characterize the cost as ballooning. I would actually characterize it as the proper scope with the contractor, Accenture, was determined after they got going. And the reason for that, and if you don't mind me saying, is because Accenture needed to be brought in a urgent situation to take over for a contractor that was leaving. And so they agreed to an initial amount, and this was before my time, and then agreed that they would come back after they got started the transition from CGI, and then they would come to terms with how much the scope ought to be.
Mr. Slavitt, in my remaining time, let me ask you this. You've been with CMS now for, what, 3 weeks?
3 weeks.
And you're the number 2 guy there, right?
Correct.
You know, when back in 2009, 2010 time frame, when we marked up this bill, a lot of us on this side of the aisle felt like that if the American people were going to have this Affordable Care Act, Unaffordable Care Act forced down their throat, that members of Congress and members of the administration, the president, cabinet members, political appointees like yourself, you're not a career bureaucrat.
That's correct.
You've been appointed by the president to come into this important position. We felt and still feel, many of us still feel, that you ought to eat your own dog food. And members of Congress, I think it's appropriate. We are doing that. We had to come off the Federal Employee Health Benefit Plan and get on the DC Health Link. And yet, you members of the administration, the president and his family, really ought to be doing the same thing. I know you worked in IT, but let's just say if you worked for Ford Motor Company, would you drive a Chevrolet? I kind of doubt it. I think you probably would drive a Ford. What do you think about that in these remaining few seconds? Respond to me. Do you think it would be appropriate as a show of good faith to the American people that you guys and gals that are running this show, that forced it upon us, would be in the same plan that the American people have to be in?
My understanding is that the president and his family are on the exchange. I don't know this for a fact, but that's my understanding. And if it's determined that the rest of us should be on the exchange, I would happily do that.
Well, if that is true, please let me know. And I know we're limited in time, and I yield back to the chairman.
Thank you, gentlemen. Yield back. Now recognize Mr. Green for 5 minutes.
Thank you, Mr. Chairman. My good friend and colleague from Georgia, who I'm going to miss. I not only drive Chevys, but I'm also on the plan. We had to buy ours through our exchange, and but I want to thank the chairman and ranking member and our witness for testifying. For decades, the United States has had the highest rate of uninsured in the industrialized world. This drives up costs and puts families at risk of bankruptcy when they get sick. The main reason is why we have a health sick system rather than a health care system, because millions of Americans can't get the care they need outside the emergency room. In our own district in Texas, a very urban district, the Affordable Care Act enabled almost 20,000 people previously uninsured to get quality, affordable coverage. Overall, the insurance rate in our district has fallen by 8%. 52,000 people in the district will have access to coverage if Texas had expanded Medicaid, and hopefully we'll still get to that. Earlier this month, the New England Journal of Medicine, not Fox News, not a left or right-wing internet site, but the New England Journal of Medicine released 2 reports on coverage under the ACA. and I like to read a quote from them. With continuing enrollment, the numbers of Americans gaining insurance for the first time or insurance that is better in quality or more affordable than their previous policy will total in the tens of millions. And, Mr. Chairman, I'd like to have unanimous consent to place that article in the record. Thank you. Mrs. Slavic, are you familiar with these reports?
Yes, at the high level.
Earlier this week, the Gallup poll released their own latest total numbers of Americans having insurance. Are you familiar with that survey?
Yes, I am, Congressman.
Similar to the Urban Institute and Commonwealth Fund conducted surveys. Can you discuss that also?
I'm familiar with those too, yes.
Okay. Would you agree that the findings of both Gallup and the New England Journal of Medicine are consistent with the millions of Americans signing up for health care?
They're consistent, very encouraging.
Okay. At this point, the only thing keeping millions more Americans from signing up for the coverage is the refusal of Republican governors and state legislatures to expand Medicaid. If they did, another 5 million Americans would be eligible for insurance. Mr. Chairman, I think the Affordable Care Act, obviously coming out of the chute, it was a problem. But it's been fixed, and hopefully we'll see in the renewals that happen. But it is working, although a lot of us had tough times in October and mid-November who supported it. Ms. Slavic, what is CMS doing to address the execution of the technology lessons learned from the first enrollment section?
Well, Congressman, I got to this project when it was beginning the turnaround stage at the end of October, and I think what we're doing now is essentially carrying over from what, just as we did in the turnaround. There's no magic to it. It's basic blocking and tackling. It's good communication. It's, quite frankly, a lot of the recommendations that have come out of the GAO report and making sure that we have precise requirements. It's daily management. It's senior-level accountability that goes all the way up to the secretary.
You know, I advocated in Texas, having served a lot of years in the state legislatures, that we should have had a Texas plan that we could have done. Some states had good examples of their plan, some not. Could you talk about that? Like, I know the state of Maryland and some other states had problems, and I don't know if they're fixed or not. But were they similar to what we had on a national scale for our states that didn't have a state plan?
In terms of the challenges, or just in terms of what they got done in their state?
Yeah, were they on a smaller scale having the same challenges that we were?
I think it's probably safe to conclude at this point, towards the end of 2014, that it was the rare state, maybe Kentucky is one of them, that didn't underestimate how difficult this would be, given all of the complexities of tying into Medicaid, tying into insurance companies, offering the consumer website. And the first year of any new program, in my experience, whether it's public sector or private sector, sometimes bumpy. Same is going to be true in the second year. But those problems become more and more minor, and we get better all the time.
To the best of your knowledge, for example, if a state wanted to create their own plan now, there's nothing in the law that would prohibit them from approaching CMS or HHS, either that or expanding Medicaid coverage.
That's correct.
Okay. Thank you, Mr. Chairman. I'll yield back my time.
Chairman yields back. Now recognize Dr. Burgess for 5 minutes.
Again, thank you, Mr. Slavitt, for being here. You heard my comments during the opening statement about the memorandum that Mr. Cohen suggested that I might have, and I just want to underscore that that is important to me, and even though Mr. Cohen is no longer at CMS, I would very much like to see that.
It's my understanding that we've just sent it. We recently sent it, so if you don't receive it, I'll follow up with your office and make sure that you have it.
Very well. You know, and it's kind of, I was just thinking, it was a year ago, really right now, that your boss, Marilyn Taffner, was here, and we talked about some things about the upcoming launch of healthcare.gov. But, of course, that was just a little less than a month after the unilateral decision by the president to delay the employer mandate. And I remember asking Ms. Taffner about was she involved in that decision, and she asserted that she was not. I asked her how she found out about it. She said her chief of staff told her, which I found rather astonishing. If my chief of staff came and gave me information like that, I mean, I would be curious as to where that came from, and she seemed to lack curiosity about how that decision was reached. But let me ask you this. We're a year later. The employer mandate is now supposed to kick in about a week and a half after Election Day in November. Is it your understanding that the employer mandate will, in fact, be enacted in November, or can we expect a further delay of that?
So I'm still working my way around the federal government, trying to understand how it all
Good luck.
works. Thank you. My understanding, and you could please correct me if I'm wrong, is that is a IRS and Treasury area of responsibility. So I haven't been exposed to that so much yet.
My personal belief is that we'll never see the employer mandate. I have no inside information, obviously. I'm not speaking for the committee. I'm just speaking for myself. When you look at the disruption that was caused in the individual market, October, November, December of last year, and remind yourself that that was only 15% of the insurance market that had that convulsion. Had that happened to the entire, both the large group market, the small group market, the individual market all at once, it would have been pretty disruptive. Now, you heard Mr. Gingrey talk about members of Congress and members of the administration should take same thing people have to take. I agree with that. In fact, I did not take the DC exchange that was offered to members of Congress and their staff. I said, look, I'll do what other people in my district have to do. I went to healthcare.gov, bought a bronze plan off the website. Biggest mess I've ever been involved in my life, but I finally got through. Took about 3.5 months to do so. Now I'm wondering what my rate is going to be next year. I've got the most expensive health insurance policy I've ever had, an enormous deductible. But what can I look forward to in the next insurance year? You talked about you wanted a successful open enrollment. Is it going to be successful? What are the rates going to look like?
Yeah. So I think we're at a stage now where, and indeed this is one of our high measures for success, is making sure that there's enough choices and enough affordability. And of course, each state is going through their own process and going through rate reviews. We have seen some states publicly now come out with their rates. I believe Rhode Island, Washington, California today is going to have, I think, an announcement with what their rates are. I couldn't tell you, Congressman, about Texas because I don't know. But generally speaking, what we've seen are rates that are in not the double-digit increase levels, but in the mid-single-digit levels. That's not going to necessarily be the case in every county in America, but that seems to be what's happening on average.
But still, I mean, you mentioned, I think, 3 or 4 states where we've got a long way to go before renewal rates across the country
no question.
are in evidence.
No question.
I mean, you're the principal deputy administrator. Do you have any responsibility or involvement in the renewal or the rate filings?
I think these rate filings get reviewed and approved, at the state level. There is a process, and I think we're in mid-process. I believe right now that
Let me just interrupt you because my time's running out. Do you receive interim reports or updates on what those state filings are?
I think there's been an initial submission, and I've seen a high-level report, but this is not yet final information.
And is your office going to make those rate filings public information? Will we have the availability to access that?
When they become final, absolutely. Absolutely.
Again, as a healthcare.gov member from the state of Texas and the federal fallback, I would very much like to know what my renewal rates are for next year. Thank you, Mr. Chairman. I'll yield back.
Gentleman's time has expired. To recognize Ms. Schakowsky for 5 minutes.
Thank you, Mr. Chairman. I just wanted to tell you, Mr. Slavitt, I don't know if your office and your position is actually in charge, but we have gotten tremendous cooperation from CMS when we have had constituent issues. And, clearly it comes up. Consumers get confused, have a lot of questions, have some problems. I get irritated sometimes on the other side. I feel like there's an embracing of these problems rather than a constituent service attitude to fix the problems. And when we've tried, we've had good success. And so I just wanted to tell you I appreciate that. I also just wanted to say that the minority staff has done a district by district, the benefits of the health care reform law in all the districts in the country. And It's just wonderful to see how the number of people that in my district, 283,000 people in my district, including 51,000 children and 120,000 women, now have health insurance that covers preventive services without any co-pays, co-insurance, or deductibles. Needless to say, that is huge.
Very good news.
And up to 36,000 children in my district with pre-existing conditions can no longer be denied coverage by health insurers. It's just lots and lots of good news, including the new Medicaid enrollees that are now being covered. But I did have a question. So we were talking somewhat about the states that have expanded Medicaid and have not. 26 states, the District of Columbia, have expanded Medicaid coverage under the Affordable Care Act. And in those states, Medicaid is seeing great success. Enrollment has increased substantially, and the percentage of the population without insurance has declined dramatically. And I'm asking you, Mr. Slavitt, if you have seen studies that compare the decline in the number of uninsured in states that did and did not expand Medicaid.
Yes, I have seen those studies.
And can you tell me what you found?
The states that have expanded Medicaid, and I'll get back to you on the exact figure, have seen significantly lower rates of uninsured than those states that did not expand Medicaid.
But we've seen a decline in any case in most. Is it in all states?
Decline in any case, and a bigger decline in states that have expanded Medicaid.
And have you seen the estimates about the number of Americans that would receive health care coverage if all 50 states expanded Medicaid? Do you know the size of this estimate?
I believe that it's an additional 5 million, if I'm not correct, if I'm not mistaken.
Thank you. And if that is the case, then I believe you that it is. This is really an appalling number: 5 million Americans who would receive health care coverage if Republican governors and state legislatures took the simple step of expanding Medicaid. It's obviously good for people when more people have health insurance. But Mr. Slavitt, what about health care providers? How does the Medicaid expansion help them?
So my information is anecdotal, but it appears that with the dramatic reduction or significant reduction in uncompensated care, it appears that this has been a very good thing for providers.
And this committee has spent the last 3 years looking for some Affordable Care Act related scandal, and despite all their concern, they have systematically ignored an ongoing health care tragedy, the dereliction of duty by Republican governors around the country who refuse to expand Medicaid. For those who have not been following this closely, the Affordable Care Act provides 100% federal funding for the first 3 years to states to expand Medicaid coverage to millions of low-income Americans, right?
That's correct.
And yet, for some reason, Republican governors in dozens of states have refused to expand coverage to low-income insured individuals in their states, correct?
That's correct.
Well, this, to me, is a real scandal. The expansion doesn't cost states a dime. It provides quality, affordable coverage for millions of Americans working hard just to get by. Yet some Republican governors and state legislatures are deliberately refusing to provide coverage to millions of uninsured Americans. And, Mr. Chairman, that, it seems to me, is an issue the subcommittee really should look into. And I yield back.
Gentlelady yields back. Now recognize Ms. Blackburn for 5 minutes.
Thank you, Mr. Chairman, and thank you for being with us today. Overseeing this implementation, getting to the bottom of a lot of the questions, I think is very important, and continuing to do our due diligence. And I know that several people have mentioned the New England Journal of Medicine article from last week, the health reform and changes in health insurance coverage. And my friends across the aisle have wanted to tout that as being something to prove their point. I think that it's important, though, to go in here and look at how the authors came to the conclusion that 5.2% more had insurance, that there was a decline in those without insurance from September 2013 to June of 2014. And then the authors mentioned the limitations of their study. They said that the study did not distinguish between persons enrolling for the first time and those who were changing their enrollment, and I really wonder how many of those that had to buy more expensive policies, new policies that were Obamacare compliant. How did that affect that number? And the authors measured improvement in access to care by asking two questions. First, did the survey participants identify a personal doctor? And second, did the survey participants report difficulty paying medical bills? Well, it seems to me a more important outcome measure would be whether a person was actually able to see the doctor. Because in our district, we hear from people they can't get access to the doctor. They've got access to the queue because they've got a card. They can't get access to the doctor. So while my colleagues across the aisle talk about how many people have insurance, I would like to remind everyone that having an insurance card is not the same as having medical care. And I continue to hear from people in Tennessee who lost their health plan. They liked it. They can't keep it. I hear from people that have not been able to keep their doctor because of the narrow networks in Obamacare. I hear from people who go to the doctor and need a test but can't get the test because their co-pays and their co-insurance are too high. They can't afford it. This stuff is too expensive to afford. And finally, we're hearing from some of our Tennessee insurance carriers, they're going to have a 19% increase in the health insurance premiums in 2015. So it's kind of like adding insult to injury. You've got the stuff, you can't use it because it's too expensive to afford, the co-pays are too high, you have an insurance card, but you can't get in to see the doctor, and you're having to wait. I don't understand why my colleagues across the aisle continue to defend this thing. But today we are shifting our focus to oversight and the way that taxpayer dollars, I remind everyone, taxpayer dollars are paying for this, and the people don't like it. On January 1, 2014, HHS certified to Congress that the American Health Benefit Exchanges, the marketplace, were verifying their applicants for advance payments of the tax credits. Cost-sharing reductions were indeed eligible. However, the GAO secret shopper investigation found that 11 out of 12 secret shoppers were able to obtain health insurance and qualify for premium tax credits using fictitious identities and fraudulent documents. Now let me, for the benefit of my colleagues, talk a little bit about what a secret shopper program does. When I had my marketing business, we would run secret shopper programs for malls and shopping centers and chambers of commerce. You identify where your problems are, and then you get in there and you clean them up. The problem is the system allows fraud. If you've got 11 out of 12 that something is wrong, Mr. Slavitt, that is a failing grade. There have been over 30 delays in implementation. The President has made multiple unilateral changes. And, you know, we're here to learn about the contracting practices that took place at CMS with the botched implementation of this law. We're looking at the GAO study. This thing's not much better. Let's talk about this contract. So, January, CMS awarded a contract to a new company to continue work on the federal marketplace. It was a $91 million contract, correct?
Correct.
Okay, now GAO says that cost has ballooned to more than $175 million. Is that correct?
You can answer that question.
It's what the report says. I don't agree with that characterization, but it is what the report says.
Okay, thank you. I will submit the rest of my questions. I yield back.
Thank you. Now, they just called a vote. We'll go through Ms. Elmer's questions, and then we'll take a break and come back for the second part. Ms. Elmer is recognized for 5 minutes.
Thank you, Mr. Chairman. And thank you for being with us, Mr. Slavitt. I'd like to go back to a little bit of the discussion you had with my colleague from Ohio, Mr. Johnson. I know you had made some comments there at the end where you pointed out that in the real world and, you know, that things are much more realistic and that ideologically many times things seem like they're going to be better than they are. I would say to you, sir, that that is exactly why I ended up running for office, being a nurse, because I did see, and my husband as a doctor saw, that the plan that was going forward was not going to be realistic, and I think we have learned over time that that is the case, and that there were many promises made that have not been kept. Well-intended, but not true for the American people. So I do, again, I share with you that same sentiment, but realize, too, that that is why we feel so strongly about this issue, that the American people do need to see what can be realistic and achieved in good health care in this country and good health care coverage. You did also have an exchange with Mr. Johnson on the cost of healthcare.gov and what it should have cost. You reluctantly did not answer the question of, you know, the cost being $1 billion. Is $1 billion too much for the implementation thus far?
So, thank you, Congresswoman. I've not seen a study yet which looks at what the appropriate cost for building the entire healthcare.gov system should be. But of course, I do acknowledge that our colleagues at the GAO pointed out that there were absolutely inefficiencies and waste in the way the contract was managed. So at the very least, we know there was some. I would hesitate to say, though, that it was entirely waste, because there was a really significant set of systems built, and I think those systems have significant long-term value for the country.
You know, there again, it gets back to that same issue of what is realistic, what is achievable, and, you know, simply throwing money at it and then looking back in hindsight to determine what did work and didn't. I think we all are learning from this experience, so that, of course, has value. I don't know how you measure it, but the American taxpayers are still on the hook for this. And that is, again, why we are taking the approach we are, which is, you know, when is it going to be enough? When are we going to achieve the goals at a cost-effective measure? I want to look into some of the issues with security breaches. Are you aware at this time of any problems that the website, from the building of the website, and that there are still concerns? Are you aware of any right now?
So there have been no successful malicious attacks, and certainly to the best of my knowledge, no one's individual data has ever been compromised from the healthcare.gov website.
So, to the best of your knowledge, and just based on the answer that you gave, you are not seeing that there were any related information breaches in healthcare.gov or traveling through the federal exchanges that you would consider a security breach?
We have not seen any malicious attacks that have been successful, and we've not seen anybody's personal information in any way get compromised.
What is the definition of a successful?
Well, I'm not trying to be cagey, but other than to say that nobody has successfully penetrated the security system to the best of my knowledge, Congresswoman.
Are you aware of any companies building, operating, or otherwise working on federal exchanges, obtaining access to information that they should not have? Anyone who's outside of the system or working on that have?
Not to my knowledge.
And information on enrollees or applicants, none there as well?
No, not to my knowledge.
Are you aware of any changes to site protocols or standards to address breaches to access information?
I think it's fair to say that the security team does continuous monitoring and makes changes and puts in new patches as as different security things are found out about in the industry and so forth. So there's a continuous monitoring.
Can we obtain that information over time? Any of the changes and updates that may have taken place for the committee?
Sure. Let me figure out what I can share. I obviously don't want all of the things that our security team does to be well understood by the wrong people, but I want to make sure to get you the information you need.
Okay. Thank you. Thank you, Mr. Chairman. I yield
Thank
back.
you. They have call votes. Mr. Slavitt, we thank you for your testimony. Members will have a few days to get other questions to you, and we would appreciate a quick and thorough and honest response.
Mr. Chairman, can I move to strike the last word just very briefly?
Sure.
I just want to Dr. Burgess had mentioned earlier that HHS didn't respond to the committee's request for an analysis of its legal authority to make payments in connection with the risk orders program. I've just been told that HHS did respond to the request and provided a response to the committee on June 18, 2014. And in the response, they also included a legal analysis. So I wanted to clarify the record, and I wanted to also make sure that if Dr. Burgess or you or the committee staff did not receive that, we will get another copy to you.
Dr. Burgess?
Well, in fact, I did not receive it, but would be anxious to look at it and see if it answers the question as it was asked. Mr. Chairman, if I could have the indulgence of one brief follow-up,
yes.
Mr. Slavitt. Mr. Slavitt, we've heard
brief.
a lot of discussion about the fact that when this thing went live, the back-end part of the system was not built. Is it now built and available and ready to use, the part that pays providers?
So the part that pays the issuers are getting paid today.
How about the doctors and hospitals?
Doctors and hospitals get paid by the health plans, not by the exchange, not by the marketplace.
So, okay, so the back-end part of the system is up and fully functional?
No. The back-end part of the system is going through continuous releases. Today we are paying the issuers on an estimated basis. There will be a coming release this year where, by the end of this year, where they'll begin to get paid at a policy level basis, and then next year, continued automation will occur to tie everything into the back end of CMS's systems.
Okay. Well, Mr. Chairman, just begs the question, have the right people been paid the right amount of money? These are taxpayer dollars that are
what we'll do is we'll follow up with some questions.
I'll be happy
to
to follow up.
Mr. Woods, we will probably reconvene. Our votes will probably take us to 11:30. So this will be in a brief recess until 11:30, and we'll be back. Thank you very much.
Well, that for nothing. He said all this. Yeah, nothing. No. Thank you. All right. Fine. Thank you so much. Thank you.
This reconvenes the Subcommittee on Oversight and Investigation. I would now like to introduce the witness on the second panel for today's hearing. Mr. William T. Woods is the Director with Acquisition and Sourcing Management Team at the Government Accountability Office. He provides overall direction for GAO's review of contracting activities at defense and civilian agencies. I will now swear in the witness. You are aware that this committee is holding an investigative hearing, and when doing so has the practice of taking testimony under oath. Do you have any objections to testifying under oath?
None whatsoever.
The Chair then advises you that under the rules of the House and the rules of the committee, you are entitled to be advised by counsel. Do you desire to be advised by counsel during your testimony today?
No, I do not.
In that case, would you please rise, raise your right hand. I'll swear you in. Do you swear the testimony you're about to give is the truth, the whole truth, and nothing but the truth?
I do.
Thank you. You are now under oath and subject to the penalties set forth in Title 18, Section 1001 of the United States Code. You may now give a 5-minute summary of your written statement.
Thank you, Mr. Chairman. Ranking Member DeGette, it's a pleasure to be here this afternoon to talk to you about healthcare.gov and the work that we've done looking into that system. When the website was launched in October of last year, there were, of course, a number of problems. We got a lot of requests from the Congress to review what happened and why. Those requests came from both the House and the Senate, from both sides of the aisle. We got requests from committee chairs, from ranking members, from individual senators, individual congressmen across the board. And what we decided to do was to combine all of those requests and conduct a body of work that addressed all of the issues that were raised in those various requests. We have a number of engagements underway to address all of those issues. The one that we'll be talking about today is contracts, but let me just mention we have one that is nearing completion on privacy and security concerns with respect to the website. And we also have a report that is on track for issuance later this year on information technology management. That report will look at the use of best practices in the development of this information technology system. But I'm going to be talking today about our first report that was issued, publicly released yesterday, and that is on the contracting aspects of healthcare.gov. And I'm going to be talking about our three objectives. The first thing we reviewed was the acquisition planning by CMS for the website. Secondly, we looked at the oversight of cost, schedule, and performance of that system. And then thirdly, we looked at a range of contractor performance issues with respect to healthcare.gov. We focused on the largest task orders and contracts that were involved here. Our report mentions that CMS had spent about $840 million for development of the system, and that was through March. Obviously, the spending has continued, and that number is likely higher today. But as of the time that we completed our work, it was $840 million. And we focused on the largest. We reviewed in depth 2 task orders and 1 contract. Just briefly, those task orders are first to CGI Federal for development of the federally facilitated marketplace. That's basically the website itself, as well as some back office systems that support the enrollment process, the financial management process, plan management, et cetera. We also looked at a task order awarded to QSSI, and that's for the Data Hub. The Data Hub is a system that interfaces with other agencies. There are roles that other federal agencies need to play to make this system work. The Internal Revenue Service, the Department of Homeland Security to verify immigration status, et cetera. So lots of agencies have a role here. And the Hub data system is that system that allows for communication among all of those agencies. And then the third contract that we looked at is one with Accenture. That was awarded on a sole source basis by CMS in January of this year for continued development of that federally facilitated marketplace. Before I get to our specific findings, I just wanted to make an observation that there really are some common threads that run through all of the work that we did here. And those threads are, first of all, complexity. This was an enormously complex undertaking. As I said, there were lots of federal agencies involved, a number of states involved, industry partners, healthcare plans, lots of players. There were also lots of systems that had to interact with each other, and that added to the complexity. Another thread that runs through, and you'll see that when we get to the findings in a moment, is the pressure of deadlines. The Affordable Care Act itself set January 1st, 2014 as the date when the enrollment took effect. The Department of Health and Human Services backed up from that January deadline and set a October 1st, 2013 time for when the system needed to be ready to go, when they could throw the switch, the go-live date, that sort of thing. They needed to have things in place by October 1st of 2013. And that drove a lot of the decisions that were made by CMS. And then the third thread that runs through all of our findings is the changing requirements. Things were constantly evolving, which made it difficult not only for CMS personnel to keep things on track, but also for the contractors to keep up with those changes. Some of those were anticipated changes, things they knew going in, they did not yet know, but others were they were learning as they went along. Let me get into the specific findings in the three areas that I mentioned. In the area of...
could you summarize, because you're already a couple minutes over, but when we want to ask you a number of questions, so if you could just summarize your final findings. Thank you.
In the area of planning, our bottom line assessment is simple yet sobering, and that is that CMS began and undertook the development of the healthcare.gov system without adequate planning, despite facing a number of challenges that increased both the level of risk and the need for oversight. In the oversight area, we saw increasing costs across the instruments that we looked at. Both of the task orders experienced cost increases, and the new contract awarded to Accenture also saw cost increases. Those cost increases were due to a number of factors. As I said, some requirements were unknown at the time they awarded these instruments. When those costs became known, when those requirements became known, the costs increased. The cost, schedule, and performance issues were exacerbated by inconsistent and sometimes absent oversight. And then in the third area about contracting performance, we saw primarily in the CGI federal task order an increasing sense of frustration on the part of CMS of the contractor's inability to be able to comply with contract requirements and meet deliverable schedules. That frustration grew to the point where they decided not to renew the contract with CGI and instead to move to a different solution, which is to award the contract to Accenture. So those are our three findings. We have a series of recommendations to address some of the issues, and I'll be delighted to get into the specifics of that as the hearing moves forward.
Thank you, Mr. Woods. We appreciate your thoroughness and your candor in this. So as you described things like inconsistent or absent oversight, you said oversight weaknesses, a lack of adherence to planning requirements compounded by acquisition planning challenges. And when Mr. Slavitt testified earlier, he said, fortunately or unfortunately, the GAO report wasn't news. So as you're going through this, with regard to the oversight, did people within CMS and CCO know that these problems were brewing?
We saw some indication that the problems were known, particularly with the CGI issue that I mentioned earlier. That was well documented what their concerns were. Other aspects, though, Mr. Chairman, were not quite as visible. And let me point out one area. We found a number of instances, and our count was about 40, where changes were being made to the contract requirements at the direction of people that did not have the authority to do that.
Within CMS?
Within CMS. These were largely...
when you say did not have the authority, do you mean they had not discussed these with Mr. Cohen or Ms. Tabner?
Well, the only person within CMS that has authority to change the contract in a manner that increases the government's obligations is the contracting officer.
Who was?
I'm sorry.
And who was that?
I don't have the name right at my fingertips.
What I'm wondering here is, do you know if so? What the problems with the website? It took longer to develop it. The security was under question. People had problems signing up, and with inconsistent or absent oversight. So I'm wondering, in some cases, you're saying there was actions taken without authorization. Several dozen of these, I believe, that's documented. So people were making change orders, and that was leading to some problems. But there was also absent oversight. So some people in charge were not meeting, were not paying attention, were not monitoring this contract, or they were monitoring some things and making the wrong decisions. Was it both or one or the other?
Combination of things. There are a number of people with different roles to play. As I mentioned, there's the contracting officer, but there is also, on the program side, a governance board review process. And that process was designed to provide high-level management oversight. And what we found there was that that process simply did not work as intended.
Now, we also had heard that there was a McKinsey report commissioned by then Secretary Sebelius, which made it pretty clear they weren't going to meet their deadlines. Did they know within CMS that these deadlines couldn't be met, and that under the pressures which you had listed, such as the January 1 deadline or the complexity of this, did they know that this really wasn't ready for prime time?
We found some indication in the files that we reviewed that in the spring timeframe, the spring of 2013, that estimates were made that the federally facilitated marketplace would only be 65% complete by the October 1st deadline.
So they knew that in the spring. Did they know that in August and September?
There was the state of knowledge continued to progress from the spring through the end of the summer, and they became increasingly concerned that the deadline would not be met. One of the principal oversight functions and processes that we saw and that we were very concerned about is there was supposed to be, according to the original schedule, an operational readiness review conducted in the spring of 2013. That operational readiness review was moved from the spring to the fall, to September of 2013, just weeks before.
And when they did that review, did they know it wasn't going to work?
Well, as I said, there was some indication in the files that they thought only 65% complete.
So when Ms. Havner
the purpose of that operational readiness review is to either confirm that the system will work or find out what's wrong. So there's enough time to fix it.
So when Ms. Havner came before this committee, or more specifically, when Mr. Cohen came before this committee within days of the launch, and he said everything was going to be fine by October 1, what you're saying to this committee is there was ample evidence to say that was not true.
We saw some indication that there was progressively increasing knowledge that there were problems in meeting that launch date.
And did Mr. Cohen know that?
I don't know that.
But either through lack of oversight, he should have known it, or he knew it and reported to this committee under oath that everything was fine on August 1, it was going to be ready for launch. What you're telling us, there's ample evidence in what you reviewed that people within HHS knew it was not ready, and people under oath told this committee something entirely different.
Yeah, I don't know what specific individuals knew or did not know, but we saw evidence in the files that we reviewed that there was a knowledge within the agency that the operational readiness was in jeopardy.
Thank you. I'm over time. We'll now turn to Ms. DeGette for 5 minutes.
Well, this is an important issue. So you're saying people within the agency knew that the website was not ready, correct? Yes or no?
We did. We saw.
You saw yes or no, that people. Do you think that people in the agency knew that the website would collapse on October 1st? Yes or no?
I can't speak to that.
You don't have any.
particular
Do you have
characterization.
indication from the files that people in the agency knew that the website would not work on October 1st?
Yes, we saw that, yes.
Can you produce that to this committee, please?
There was a series
No,
of...
can you produce
Absolutely,
it?
ma'am.
Thank
Yes.
you.
Yes, ma'am.
Now, my next question, because Ms. Taverner and Mr. Cohen did come in here and testify under oath several days before, as the chairman has said, that the website would work. Do you have evidence in your files that Ms. Cohen or Ms. Taverner knew that this website would not work? Yes or no?
No, I cannot
Thank
speak
you.
to the knowledge of any individual.
In your opening statement, you talked about some provisions the GAO was coming up with to strengthen the website for some recommendations for privacy and security concerns. Is that correct?
Well, this particular report that we're speaking to today just deals with the contract.
Right, but you talked about...
Not for security and privacy.
Okay, so you're not looking at privacy and security?
Other teams within GAO are looking at, and that work...
Are you aware of any security breaches in the websites? Yes or no?
No, I'm not.
Okay. Now, the GAO made 5 recommendations you referenced in your opening statement to CMS to avoid the mistakes that you had identified. Is that correct?
Yes.
And I just want to go through those recommendations because you said we should, and I think it's important to know. The recommendations, I think, are good recommendations, but they're a little vague. And so I'm going to ask you about each one of them if you have specific details, but then also I'm going to ask you, Mr. Woods, to supplement your testimony and provide to this committee and to CMS specific details on each one of them, because I think it's important for the CMS to actually be able to implement these recommendations. And our last witness said he agreed with the recommendations and he did want to implement them. The first recommendation is that CMS should take steps to assess the causes of the increase in costs of the continued development of healthcare.gov and the delays in functionality of the website, and develop a plan to mitigate those costs and delays. Can you briefly give us a little more detail on what steps the GAO believes CMS should take to make those assessments?
Certainly. Well, we did see cost increases in the Accenture contract, the current contract.
So what steps do you think CMS can take to rectify these problems?
We think that they need to step back and identify the causes, the reasons why costs continue to increase in that particular contract.
Okay. And do you have any thoughts what should be included in a mitigation plan?
They need to make sure that costs are under control and that the schedule can be met.
Yeah, I think those two things are key. Now, the next thing the GAO recommends is that quality assurance surveillance plans and other oversight documents are collected and used to monitor contract performance. How can those documents be effectively used to monitor performance?
The quality assurance surveillance plan is a standard document that's required in most efforts of this size that provides a roadmap for how the agency, any agency, is going to oversee the contractor's performance.
Right. Does the GAO have thoughts on how it can be used to do that?
Yes.
Okay. If you can give us that information, that would be great. I want to go through your other recommendations briefly while I still have time. The GAO also recommends that CMS formalize existing guidance of the responsibilities of personnel assigned oversight duties. So, as I understand it, the roles and responsibilities were spelled out in some way. How would formalizing existing guidance prevent confusion about the responsibilities and authority going forward?
This gets to the issue of unauthorized individuals making changes.
Great.
And when they learned of that, there was internal guidance provided to all of the people but that has not been institutionalized. It has not been made part of the permanent guidance at...
Okay, so they already have a way they're doing it. That just needs to be formalized.
They need to take the next step.
Perfect. Now, the next thing, you recommend giving staff direction on acquisition strategies and developing a process to ensure that acquisition strategies are completed on time. Can you flesh that out a little bit for us?
That was a very important
Yes.
deficiency that we identified, is that there were a number of steps that CMS took to expedite the rollout of this, of healthcare.gov. But each of those individual steps added risk to the process. And the purpose of the plan, of the acquisition strategy, is to, first of all, identify those risks, to be able to come up with a plan to address them, and we found that acquisition strategy was
Right.
not prepared.
So does GAO have some ideas what this process could look like if done appropriately?
The process is already in place.
Okay.
The regulations at HHS are very clear. In fact,
Okay.
there's a template. It just wasn't done in this particular
Oh, great.
case.
So they just need to follow the existing regs.
Exactly.
Perfect. Last, you recommended ensuring that information technology projects adhere to the requirements for governance board approvals before proceeding with development. What exactly does that mean? What governing board are you referring to? What are the requirements? And why did the board approval process fail the first time around with healthcare.gov?
Yeah. The agency had a system in place that provided for an oversight board to review the progress of the system. The problem that we found is that those governance board meetings were held with incomplete information, and that decisions were not made as we would have expected to either approve, disapprove, or make modifications in the...
So what you're saying is, once again, this was a failure to follow the existing rules that they have.
There was a process in place. They did not follow it.
Thank you. Thanks for your indulgence, Mr. Chairman.
Yes, now recognize Ms. Elmers from North Carolina for 5 minutes.
Thank you, Mr. Chairman. Thank you, Mr. Woods, for being with us today. You know, as I'm sitting here listening to your report findings, I am incredibly amazed by the inefficiency that went forward with a plan of action that was in place. And I keep coming up with the same question of why. Why were these steps taken? Why was action taken the way that it was? Why were there unauthorized individuals making decisions? But I think one of the most glaring questions that I have based on your findings is that, and you use the word that they expedite, you know, they took measures to expedite the rollout, that added risk, obviously, and that was a failed strategy, essentially. Why, in your opinion, based on your findings, did they stay with that October 1st rollout date when they knew, based on what I'm listening to, that it was not going to be accurate and successful, and that it would be a failure?
Well, the law itself, the Affordable Care Act, set a hard deadline of January 1st, 2014. And they needed to have some period where consumers could determine their eligibility, look at plan availability, and make decisions about what plans they wanted to choose by that January 1st date.
So they stuck with the October 1st date knowing that their time was running out, and that they, so now this is me just, again, trying to process why they would go forward with something that obviously was not put together well, and steps were taken. It wasn't an efficient system, and yet they were moving forward. So based on your knowledge, they had to go forward with that October 1st date so that they could have the enrollee numbers that they were looking for by January 1st, regardless of the fact that it wasn't going to work.
That's been CMS's position, is that they needed to stick with that October 1st.
They had to stick to that date because they needed those numbers of individuals signing up, essentially. Yes?
Well, they needed to comply, to have a system in place by October 1st, by January 1st, in order to comply with the Affordable Care Act.
Okay. So I'm going to go back to some of the questions also on the tech surge. When the tech surge was implemented, to the best of our knowledge and based on your report findings, we understand that there was again, tech surge in October to fix the site after healthcare.gov's failed October 1st launch. based on your investigation, what actions did CMS take in October to fix the site?
In October, they continued to work with CGI Federal, but the level of frustration reached the point in November of 2013 where they sent yet another letter detailing the shortcomings of the contractor, asking for a corrective action plan. CGI responded to that and clearly disagreed with CMS's assessment at that point.
Okay, so they were disagreeing with it. So was CGI's, I mean, 'cause there were other contractors involved too, is that correct?
There were many other contractors involved, right?
Okay, but particularly it was CGI that where the frustration was, where the disconnect was.
They were responsible for the heart of the system, if you will.
Okay.
And that's where the most of the dollars were in terms of contract expenditures.
So to that point, based on the fact that CGI was the main contractor for that, were there other contracts, or was their contract extended? Were there any new issued contracts based on the frustration that CMS had?
The CGI contract had been extended earlier until February of 2014.
And that was before October 1st?
I believe that was
okay,
before.
So it was already extended before October 1st.
That's correct.
Okay. Then to that point, were there any other, again, getting back to this, were there any other contractors that were selected knowing that CGI was not necessarily doing what was necessary for the repair of the website?
The only contract that I'm aware of is the new one to Accenture to continue with development of the federally facilitated marketplace.
And can you refresh my memory on when that actually took place, when the new that new contract went forward?
That was January of 2014.
That was January. Okay. Okay. Well, Mr. Speaker, or excuse me, sorry, Mr. Chairman, I've gone over on my time, and I apologize. Thank you. Thank you, Mr. Woods.
Thank you. I'm now going to recognize the gentleman from Virginia, Mr. Griffith, for 5 minutes.
Sorry. Thank you so much for being here today. I appreciate it very much. The report indicates that CMS did not engage in effective planning or oversight. What do you recommend they do in the future to make sure they have proper planning and oversight? Because they apparently dropped the ball.
They have the tools in place.
Okay.
One of the primary tools is a strategic plan, an acquisition strategy is what it's called. There's actually a template in the HHS regulations for each of the areas that needs to be addressed. And fundamentally, it's a tool designed to identify the risks that the agency is undertaking and to be able to come up with a plan to be able to mitigate those risks. But they did not follow it. So the tools are there. They did not use the tools that were there.
Now, I'm going to ask you an open-ended question because I think it's important that we get this perspective from time to time, and that would be, out of the report, what have we not asked you about that we probably should have asked you about, or the people watching this at home, something that they ought to know about your report that you haven't already covered in your testimony here today?
Well, one thing that comes to mind is the next enrollment period. I think people are wondering, are we going to experience similar problems, or are we in better shape? And that's why we have one of our recommendations that's focused on the current contract with Accenture, where we've seen some cost growth, and we think the agency needs to make an assessment of why that cost growth has occurred, whether they are in fact on schedule, and whether there are any risks to the 2015 enrollment period.
Now, my hearing's not as good as it should be. You're talking about the cost growth? What was that phrase you used?
Cost increases.
Okay.
And we have somewhat of a disagreement with the agency about the term cost growth, and that's why I'm reluctant to use it. Their position is that any cost increase since about April of this year is totally based on new requirements. So it's unfair to call that cost growth. Our position is that when you look before that, when they initially awarded that contract at an estimated value of $91 million, and now it's at 175, that the agency needs to make an assessment about why those costs increase from the 91 to the 175. Well, and let me just and that's not the end of it. There are that contract continues in place today. Our numbers are dated in terms of we completed our audit work a couple of months ago, so costs on that particular contract are almost certainly higher today than they were at the time that we completed our audit work. We think the agency needs to make an assessment about why costs continue to grow.
Well, I think they do as well, and I appreciate you raising that point. And it's kind of interesting. It would seem to me some of those new requirements are probably because it didn't work the first time around. Wouldn't you agree?
There are enhancements to the system. Mm-hmm. They're constantly changing and trying to make improvements to the system. The ones that early on, I think you're right that those are related to the inability of the system to function as intended originally. But the agency tells us that the more recent cost increases are due to enhancements.
All right. Well, I appreciate that, and I appreciate your testimony here today. And I'm happy to yield my last 55 seconds to whomever might want it.
I will. Thank you. Thank you. I do have one follow-up question, and it has to do with the conversation you were just having with my colleague. When we're talking about the cost increases, you had mentioned that that enhancements are what has been cited as the reasoning. My question for you is, did CMS get congressional approval for the additional funding or spending, I guess I should say?
I'm not aware of what that process was at all.
So to your knowledge, based on the report, you did not see any effort put forward to come to Congress for additional funding for spending?
I can't speak to that. We didn't see it, but that wasn't part of our review.
Okay. Thank you, Mr. Woods, and thank you to my colleague for yielding.
Thank you. I'm going to do a second round with Ms. DeGette and I. So is this a follow-up here? Are you saying that CMS is not analyzing why the contract with Accenture is growing in cost?
We don't think that they have done that fully yet.
This original contract, which was a cost-plus contract, who signed that contract? Who's responsible for that?
Those contracts are signed by the contracting officer, and as I said, I don't have that name.
Do those have to be approved by Mr. Cohen or Ms. Taverner? You know, in that chain? Is that something that your study encompassed to find that paper trail or look at that?
We did not review that, no.
Let me ask you, too. You talked about the pressure of deadlines, January 1, 2014, but a number of delays were put into place, the employer mandate, early retirement issue, enforcement of canceled plans, individual mandate to the shop plan. Should the rollout have been delayed as well?
I'm not sure about that, but your observation about delays is accurate. When they realized that they would not be able to be fully functional by October 1st, they did make some trade-offs and pushed projects that they thought they were initially going to be able to complete by October 1st, pushed that off into the future. And the small business program that you mentioned is one of them. The financial management module was also pushed off until a later date.
Now, but none of those delays caused a delay in the website. Those were none of those. Many of those things I mentioned, they didn't cause a delay in the website readiness. There was these several dozen other changes internally which were one of the factors in delay in the website readiness. So, am I correct?
Well, the website was launched. I'm not sure.
But you had said a number of decisions made during it. I guess it was 2013 or 2012. Were part of the complexity that added. You've mentioned a couple main things. One, there wasn't proper oversight of the contract. And the second thing, a number of internal changes were made by someone who didn't have the authority to make those changes.
That's correct.
So do you know, or can you find out for us, in terms of if someone's making these changes, who approved the decision for them to make these changes, or who gave that person the authority to be in that position to make those changes? Do you have that information?
There are a number of people working with the contractors on a day-to-day basis. And the 40 instances of changes or direction to the contractor was made by multiple individuals. Some of these were technical people, as I said, working side by side with the contractor. Some of them were more senior officials. All of the changes, though, ultimately were ratified by the person with authority to do that, and that is the contracting officer.
But what, did it go to the level of Ms. Tavener or Mr. Cohen?
I don't know.
Is that something your records could review? This is a follow-up to what Ms. DeGette was asking as well. We need to know if your records show, or if you can find out for us. I don't think you have an excellent investigation, but it's very important to know this. If they knew or should have known, in terms of approving these changes, or being aware that the website wasn't ready, well, let me ask that part. Do you have any information on those?
Well, as I said, we'll certainly review our materials and provide an answer to that question.
Because it comes to this point. This committee, members of each side of the aisle, has different points of view on issues with regard to health care reform. That's fine. That's part of what makes our nation great. People have differences of opinion. They move forward on that. But there are certain standards within a committee that I think we should be unified in understanding, that if someone comes before this committee under oath and claims that something is ready to roll on October 1, that everybody should be able to sign up, knowing full well that it's not, it's either incompetence, it's dereliction of duty, it's sloppiness, it's lack of supervision oversight, or it's perjury to this committee. It's perjury in terms of making a claim they know is not true, or making a claim they have no business of making. The only answers to questions like, is the website ready October 1, or yes, no, or I don't know. Anything beyond that, when the claim was made by Mr. Cohen to this committee under oath that October 1 everybody would be ready to sign up, it's clear from your investigation and your testimony that people within the agencies knew it was not ready. So any information you could provide us that tells us if they knew and made false claims as committee, or if they didn't know and made false claims as committee, it's important for the integrity of this committee to let us know. And if you could submit that information to this committee, I'd be grateful. Your papers and other reviews of that. Ms. DeGette, recognized for 5 minutes.
Thank you very much, Mr. Chairman. And Mr. Woods, I can understand why the chairman is concerned about this based on your testimony today. So I want you to think very clearly about what your investigation found and what you have testified to this committee today when I ask you these questions. Because I don't want the record to be confused, and I don't want a misimpression to be left. Are you aware of a either Ms. Tavener or Mr. Cohen coming before this test committee and lying about whether they knew that the website was not ready?
No, I cannot speak to that. I don't know.
You don't know. Do you know whether Ms. Tavener or Mr. Cohen personally knew that the website was not ready? Yes
no,
or
I
no?
do not know.
You don't know that. Do you know whether Ms. Tavener or Mr. Cohen specifically approved those changes?
No, I do not know.
You don't know that either?
No.
Do you know who within the agency did approve those changes?
Ultimately, those changes were ratified and approved by the contracting officer.
The contracting officer. So you could give us that information,
Absolutely.
who that was.
Yes.
Thank you very much. I just think, and I know the chairman agrees, we don't want to loosely be throwing around allegations of perjury or anything else when we know, and we don't want to put words in your mouth either. So I think we're clear on that. There's one more thing I wanted to clarify about your testimony today. Your first recommendation that in your report on this topic, as we discussed, was take immediate steps to assess the causes of continued FFM cost growth and delayed system functionality and develop a mitigation plan designed to ensure timely and successful system performance. Is that right?
That's correct.
And that's the one you're concerned about CMS following as they look at implementation of the 2015 program. Is that correct?
The effort that's underway by Accenture is to move the development forward to be ready for the 2015.
And that relates to that recommendation.
Yes, it does. We
okay.
Think, we think that CMS needs to make that assessment in order to ensure itself is on track for that
for
enrollment
next year.
period.
Right. Now, you were sitting here, I believe, when we heard the testimony of the previous witness. Is that correct?
Yes, I was.
Mr. Slavitt. And I specifically asked Mr. Slavitt if he had reviewed the 5 recommendations GAO had made. Do you remember hearing that?
Yes.
And do you remember hearing Mr. Slavitt say that that CMS agrees with all 5 of the recommendations? Do you remember hearing that?
I remember hearing that, yes.
Okay, so I would just you know, sometimes I like to have both the agency witness and the GAO so that they can answer each other's issues. But I just want the record to be clear that Mr. Slavitt has said that they recognize this recommendation, they intend to comply with it, and I think, Mr. Chairman, we should follow up and make sure that happens. Thank you, and I yield back the balance of my time.
Thank you. Now recognize Dr. Burgess for 5 minutes.
Thank you, Mr. Chairman. Mr. Woods, thank you for being here, and let me just commend the General Accountability Office on great work. This has not been easy, and I appreciate how difficult it's been to be here today, and I appreciate your forbearance. Now, along the lines of what Ms. DeGette was just asking you, do you know whether or not the Center for Medicare and Medicaid Services is adopting your recommendations right now?
What they told us is that they fully agreed with 4 of our recommendations, and they partially concurred with our 5th recommendation.
Have you any evidence